All right. Hi guys, welcome to the Finals Crash Course series. We're doing Gynaecology today, taught by Aisha here. So in the top right corner is our QR code for our Instagram page. So if you're not following, please do scan and follow. And in the bottom left corner is our email. So if you have any questions, please do email us and we can always forward it on to Aisha. Go on to the next slide. So this is the QR code for the polls, and I will post the link for the polls in the chat as well. And I will hand over to Aisha.
Thank you so much, Ash. So we'll just get started. Just a little bit about myself. I'm an obs and gynae trainee in Northwest London. I studied at Imperial, and I'm very much interested in medical education, if it wasn't obvious from doing this talk today. So this is going to be a whistle-stop tour on gynecology, which is still a very large topic. And the contents of the slides and the conditions and presentations that we'll cover is in line with the MLA and GMC curriculum and content. But obviously, I would suggest that you check your own university kind of syllabus so that you cover everything that you need to know from that perspective. The SBAs and all of this is pretty much made by myself, and if there is anything that isn't made by me, there is a little point out as to where you can get it from. So just to get started, there are lots of topics to cover. I've kind of decided to split it a little bit into early pregnancy, sexual health, benign conditions, and then malignant conditions. So that's how you kind of know how far in you are. So let's talk about early pregnancy. So this is the first SBA. The poll should be open now. So it's about a 25-year-old female. She presents to A&E with persistent nausea and vomiting and generalized abdominal pain. On examination, she has a soft abdomen but looks dehydrated. Her observations show a temperature of 37, heart rate of 100, and blood pressure of 90/60. The SpO2 is 99% and RESPs are 20. The urine dipstick shows 3 pluses of ketones, and she has a positive urine pregnancy test. The blood results show a sodium of 130 and a HCG of 15,670. Her and her partner have recently returned from their honeymoon in India. So what's the most likely diagnosis? I'll give you another 30 seconds or so to answer the question. Okay, so I'm going to stop the poll now and I'm just going to go through the answer. So the answer is hyperemesis gravidarum. So she's a young female, nausea and vomiting. There are some signs to pick up on, which is that she's tachycardic and has a lowish blood pressure, although you can count that as somewhat normal for a young person. She has 3 pluses of ketones, although nowadays people don't tend to use ketones so much as a marker for kind of nausea and vomiting in pregnancy anyways. She's got a positive urine pregnancy test. The sodium of 130 is really what can define the difference between the first 2 options, your nausea and vomiting in pregnancy and your hyperemesis gravidarum, because hyperemesis gravidarum is only really, most people come in with nausea and vomiting in pregnancy. Hyperemesis gravidarum really is a complication that arises from this nausea and vomiting. So typically it will be things like a sodium of electrolyte derangement or significant weight loss that you can see, and therefore that's why hyperemesis is the better answer of the 2. It could be a UTI, but there's nothing in the urine to show that, and it could be infectious gastroenteritis, but then you would expect her maybe to have bowel symptoms. And again, it could still be that, but you've got to take into account she's got a positive urine pregnancy test. The cause of the abdominal pain, as asked by someone, is if you vomit so many times, 20 to 30 times a day for several days, they will end up having just generalized abdominal pain. In the same way that, if you have a stomach bug, you will eventually feel just generalized pain over the tummy. So hopefully that answers the question. And obviously DKA, we know nothing about her past medical history to suggest that she'd be in DKA. Perfect. So this is the second SBA. So I'm going to just open up the poll. Please do answer on the VVOX. It's a really good way to know how fast to go ahead in terms of the pace of the lecture. So again, she's a 25-year-old female. She comes to A&E. She's got persistent nausea and vomiting. But this time she's also got diarrhea and right-sided abdominal pain. On examination, she's tender over the right iliac fossa. She looks pale and sweaty. Her observations show a temperature of 37. She's tachycardic at 120. Her blood pressure is 90/60, and her SpO2 and respirates are normal. She has a positive urine pregnancy test. Blood results show a HB of 95 and a HCG of 1567. What's the most likely diagnosis? Again, I'll give you about 30 seconds. Okay, so I'm going to stop the poll now. And the answer really here is ectopic pregnancy. And the reason is because it's asking you what is the most likely diagnosis. She's pregnant, she's got right iliac fossa pain, and she's tachycardic, pale, sweaty. She's got a positive HCG. It could be appendicitis, very much so. But in view of the positive pregnancy test, you need to rule out an ectopic pregnancy first because that's what's most likely to kill you first. And it sounds like it's possibly even ruptured in this case as well, given her clinical picture. So hopefully that makes sense to everyone, although I see someone typing, so I wonder if there's a question coming my way. So the HCG is really there just to throw you off. One thing to bear in mind is HCG is something that's good to tell you. It's more sensitive as a blood test to tell you if someone's pregnant or not, because the urine pregnancy tests themselves all have different levels of sensitivity on the level of HCG present. So that's why we often, when somebody comes into hospital and they say they're pregnant, we do a HCG. The other thing is sometimes it's not always clear cut whether or not this person has an ectopic or an intrauterine pregnancy or is going through a miscarriage. And so we usually can even do serial HCGs in order to track the progress of this. So what you would expect is in 48 hours time, if this was a normal pregnancy intrauterine and she did not have an ectopic, that it would double at least in 48 hours time. So you'd repeat the HCG if you didn't have a suspicion of an ectopic or you couldn't see anything on a transvaginal scan. The other thing with HCG, just to be aware of, it has to be roughly over 1,000 for you to actually see anything, typically anyways, see anything on a transvaginal scan in terms of a pregnancy from the gestational cycle or yolk cycle or fetal pole. It usually needs to be above 1,000. So again, that's a bit of an indicator of how early or late in their pregnancy they are. So hopefully that makes sense. If it doesn't, you can type in the chat and let me know. This is the third SBA. So a 25-year-old female comes into A&E. She's also got generalized abdominal pain. And on further questioning, she tells you she's currently on day 4 of her period. On examination, she's got generalized tenderness. She's pale, she's sweaty. The speculum examination reveals a closed os. The observations are a temperature of 37, she's tachycardic at 110, her blood pressure is 100/60, and she's got normal SpO2 and rest rate. She has a positive urine pregnancy test. Blood results show a HB of 85 and a HCG of 156. What is the most likely diagnosis? I'll give you another 15 seconds. Okay, I'm going to stop the poll now and we'll go through the answers. So this is most likely a threatened miscarriage. And now this is all about knowing what the different meanings of the different types of miscarriages are. Okay, I think we can probably all agree that this is a miscarriage in the first place. She's got generalized pain and she's bleeding, although she probably didn't know she was pregnant. And this just kind of points out the importance of doing a urine pregnancy test, because especially in early pregnancy, you might not know you're pregnant and still be, bleeding. If you're sexually active, there is always a chance you could be pregnant. So let's just go through it. Inevitable miscarriage is a miscarriage that will happen eventually. And usually you can only really diagnose that if somebody has an open os, so open cervical os, and symptoms of a miscarriage, so abdominal pain and bleeding. So if in this case the os was open, the answer here would be an inevitable miscarriage. The second option is an incomplete and complete miscarriage. And the reason why it's neither one of those is because you can't tell whether it's incomplete or complete until you do a scan. With an incomplete miscarriage, the os can be open or closed, but you would need to see product. So you need a transvaginal ultrasound scan to actually know whether it's an incomplete miscarriage. And if it's complete, then the os will be closed, the symptoms would be settling, and you wouldn't see evidence of a pregnancy inside the uterus. So you just see a normal thin endometrial lining. It could be an ectopic pregnancy, but we'll go over ectopic versus miscarriage in a little bit. And typically with an ectopic pregnancy, you get pain more than you get bleeding. And in this case, I guess the thing I was trying to point out with a HB being so low and the fact that she's tachycardic is that maybe she's bleeding a lot, and so she might need further intervention for this. With a closed os and the symptoms of a miscarriage, you can only say it's threatened because you haven't got an ultrasound scan to actually prove whether or not there is still any evidence of a pregnancy inside. So hopefully that makes sense. We'll go over these things a little bit just now before we move on to the next set of SBAs. I purposely made these SBAs very similar to one another to try and kind of point the specific niche differences between the different medical conditions or different presentations. So nausea and vomiting in pregnancy is quite common. It usually begins around the 4th to 7th week of pregnancy, and it peaks about 9th to 16th week and resolves around the 16th to 20th week for most people. If nausea and vomiting starts after your kind of first trimester or towards the end of your first trimester, then usually it suggests a different cause for the nausea and vomiting. The risk factors are things like a twin pregnancy or a molar pregnancy, which is why part of your investigations when you see a lady in A&E with nausea and vomiting in pregnancy is to ensure that they have an early pregnancy scan to rule those things out. If it's their first pregnancy or if they're obese, it's also another recognized risk factor. We use something called the Puke score, which I've put here on the bottom of the slide. And I'll let you just look at that when you go home. And often this is a good way to know or a good way to decide whether or not this person can be managed as an outpatient by the GP, an outpatient through ambulatory care, or something similar to that in whatever hospital you're in, or if they need to come in as an inpatient on the gynae. And the things that it looks at is the severity of the nausea, how many times you're vomiting, and if you've got any of the other symptoms of, complications of severe nausea, vomiting, like weight loss and not able to eat and drink at all, and how it affects your quality of life. So investigations commonly is a urine dipstick to make sure that other causes like a UTI are ruled out, as well as to see if there's any presence of ketones, although, that can vary a little bit. A full blood count, Usinese, and ultrasound scan. And again, the full blood count and Usinese is to A, rule out other things like infection, and B, also to check if there's any electrolyte disturbance. So if the nausea and vomiting is really severe, then you can have electrolyte imbalances, and that's where hyperemesis gravidarum kind of comes into it, because it's really defined as something that's prolonged, persistent, severe, and you will have complications like weight loss, usually about 5% at the very minimum, and you will have signs of dehydration or electrolyte imbalance, which you will be able to see on your Usinese. If these things are refractory, you should always look for other causes of nausea and vomiting in pregnancy, such as, hypothyroidism. And the complications obviously are kind of listed there. The important one to be aware of is nutritional deficiencies like vitamin B1 deficiency. So like alcoholics, you can get wernicke's encephalopathy, but I must say I've never seen it in my life. And often you do send these people home if they come to A&E with folic acid and thiamine to go home with for at least a week, and folic acid to continue up until at least 12 weeks of pregnancy. And they're actually at higher risk of developing a DVT or a PE. So that's just something to be aware of. Ectopic versus miscarriage. Now, there's risk factors which are often very similar, things like increasing in maternal age, if you have certain chronic medical conditions, if you smoke, and specifically for ectopic pregnancies, if you've had a previous ectopic or you've got an intrauterine contraceptive device in place, or even previous evidence of kind of PID or STIs, and you're at greater risk of an ectopic. In terms of presentation, you get very similar presentations. It's usually abdominal pain and bleeding, PV bleeding, but more commonly, the way I like to think about it is miscarriage is more commonly PV bleeding is the predominant symptom, and with ectopic, it's predominantly pain that is often localized to one side or the other. You've got a couple of other extra things on the list there, which you can look over at some point. The investigations are often very similar because you need to examine them, you need to do a speculum, and you need to do some bloods, as well as a transvaginal ultrasound scan, because really that's the most definitive thing that's going to tell you whether or not where the pregnancy is really. There are different types of management for each one, and people often get the two a little bit confused. The important thing with an ectopic pregnancy is that you can be conservative. You can try and see if the body automatically ends up rejecting the pregnancy and ends up leading to a miscarriage. But there are certain criteria that need to be met as listed out by the RCOG, which are things like the fact that follow-up needs to be possible. So it needs to be someone who will be reliable to come in frequently. It needs to be an ectopic that's less than 35 millimeters in size and not ruptured. There must not be any evidence of a fetal heart activity, and no significant symptoms of the ectopic, so pain or hemodynamic instability. And the HCG level, which again is where one of the few places where HCG is important, is it must be less than 1,500. So in our case before with the ectopic pregnancy, she wouldn't qualify for conservative management at all because she had significant symptoms and she was hemodynamically unstable, and the HCG level was a little bit just above the requirement. For medical management, it's very similarly, but the HCG level is at a greater range, so less than 5,000, but ideally less than 3,000. And for medical management, we use methotrexate, which is effectively a chemotherapy agent, and it needs to be prescribed by someone who can counsel the patient appropriately on the side effects of methotrexate. One of the negative things about it is that it means, in terms of from a fertility standpoint, because it can cause congenital anomalies, if you are trying for a baby, you probably wouldn't opt for medical because you have to spend 3 to 6 months not trying for one after you finish the treatment. It's usually a one-off dose. And the final one, which is the most common form of management for an ectopic pregnancy, is a diagnostic laparoscopy, and then you usually get a salpingectomy. We only really consider salpingotomies in people who've had, say, a previous salpingectomy, and fertility conservation is very important. For a miscarriage, the management, again, very similarly, you can have conservative, so you can wait and see if the body automatically undergoes the steps of a miscarriage. And usually we say 1 to 2 weeks. Every unit will be slightly different. And if you do experience symptoms, then they usually ask you to repeat a urine pregnancy test 3 weeks later. And if it's positive, then it may be that it's not a complete miscarriage. Medical is the use of misoprostol, which is a prostaglandin and a prostaglandin analog, and effectively it initiates contractions, and so you get pain, bleeding, and sometimes other systemic effects of things like vomiting and diarrhea. It's usually 1 tablet that actually it's 4 tablets that you take as a once only event, and you just await events. Usually it starts very quickly. And then surgical management is either an MVA or it is a SMM or ERPC, previously known as. And effectively, they're both very similar. The difference is that a manual vacuum aspiration is done as an outpatient and the patient is awake, whereas a SMM or an ERPC is usually done under GA. With the manual one, it's usually it's usually kind of manual vacuum that you create with a syringe, although nowadays they do have certain devices that do use an electrical vacuum, which is what we use in surgical management of miscarriage. We're trying to step away from the word ERPC unless it really is an evacuation of retained products of conception. One point to mention is a termination of pregnancy. If somebody wants to terminate the pregnancy, they need to first use mifepristone, which is where people often get confused, which is an anti-progesterone, and that is to effectively stop the pregnancy from continuing. And then you use misoprostol. Whereas with a miscarriage, you only need the misoprostol because effectively there is no viable pregnancy present. I forgot I included this slide. It's just a little note on miscarriages and terminations, and this is a little bit more technical in the sense that it's talking about the ultrasound findings. So I've seen questions where people ask about the crown rump length and talk about the mean sac diameter in the question, in the body of the question, and really they're trying to get at whether or not you can diagnose this as a miscarriage or not. Because if the crown rump length is small, then it may be too early, and so you need a repeat scan that shows no increase in size in the crown rump length, and similarly to the sac diameter, to actually prove it is a miscarriage. Because sometimes we just do these scans too early on. With a termination of pregnancy, you've got different options. You've got medication, which is your mifepristone, and then usually the next day you have misoprostol. And then in later than 10 weeks, we usually do medical terminations up to 24 weeks, but that will require multiple doses of misoprostol. So often they stay in hospital because they'll need these every kind of 4 to 6 to 8 hours until eventually they pass the pregnancy. If they have a surgical termination, we only recommend it between 7 to 15 weeks. It's very rarely used if less than 7 weeks, and equally very rarely used after 15 weeks, because only special units can actually do a surgical termination after 15 weeks, because the pregnancy would then need to be removed in fragments. Don't forget, as pregnancies develop, things like bones develop. So actually doing it surgically after 15 weeks is often considered more dangerous than medical management. So let's go through our second section. So sexual health. So some more SBAs for you. Let me just open the poll. There. Hopefully that's open. Oh. Apologies, my phone seems to have frozen. Okay, so that poll should be open. As you can see, I seem to like 25-year-old females. And this lady has come to the sexual health clinic. She's got offensive smelling discharge. She's sexually active in a monogamous relationship. She doesn't describe any pain or soreness, and swabs reveal the presence of clue cells. What is the most likely organism to cause her symptoms? Hopefully this one's fairly easy for most people. But quite often a common question, actually. Stop the poll. And as most of you have guessed correctly, it is Gardnerella vaginalis. I don't know why I picked such a question. So the question's really trying to show you, it's a two-step question. Can you diagnose this? So it was bacterial vaginosis. And the second thing is, do you know what organisms cause BV? And BV is typically seen in people who are sexually active, but it's not considered to be a sexually transmitted infection. So that's something to bear in mind. And the reason it happens is because there is an imbalance in the naturally occurring flora in the vagina. The way it presents is an off-white, grey, offensive discharge, with a fishy odour. So a lot of the questions have that. And from having seen it, it is quite fishy. And the diagnosis is made with swabs looking at under a microscope, which looks at clue cells and also looks at loss of vaginal acidity. So usually the pH has to be more than 4.5. And the treatment here would be oral metronidazole. So this is your second question. In this one, you've got a 25-year-old female who's in A&E, who's got right-sided lower abdominal pain, as well as offensive discharge. She's been recently diagnosed with PID, which is pelvic inflammatory disease. Apologies, I probably shouldn't be using acronyms. And she was started on oral antibiotics for this. She's felt more unwell, and so she's come into A&E. On clinical examination, she's got right iliac fossa tenderness. She's got adnexal tenderness, offensive discharge. The CRP is 228. If you wanted to know the normal range, the CRP should be less than 5. And her white blood cell count is 17.9. Again, should be less than about 10.9. A urine pregnancy test is negative. You suspect a tubo-ovarian abscess. So what would be the most likely antibiotic regimen that you would start her on? Okay, so most of you, I think, got that one correct. Which is C, ceftriaxone, doxy, and metronidazole. Again, you either will know this or you won't know this. But I guess if you thought a little bit about the kind of question and the fact that she was so unwell, you probably think she needs IV antibiotics. So you were either going to go for A, B, or C, really, because the other options have oral in them. So hopefully that would have been a good one to just be able to guess, because you would have had a 50-50 chance if you used some logic. So next one, 25-year-old female again. She's seen in gum clinic. She's complaining of itching, vulval pain, and multiple lumps. She's sexually active, so what's the most likely diagnosis? Just 5 more seconds, because I think most of you got this correct from what I can see. And you are correct, it is genital herpes. Itching, vulval pain, lumps in a sexually active female, most likely to be genital herpes. I guess the only other thing maybe that I use to throw you off is the use of genital warts in there. But remember, genital warts are benign epithelial or mucosal outgrowths, and they're usually caused by HPV. They're typically not painful. So usually the difference between genital warts and genital herpes in a question will be pain. If it's painful, usually lean more towards herpes. If it's not painful, lean more towards warts. And remember, in terms of the questions that tend to come up, if they're talking about genital warts, they may ask you what organism causes it. And it will be HPV, but the subtypes that are specifically ones important to remember are 6 and 11. I know this is a very busy table, but hopefully if you rewatch this lecture again on YouTube, you'll be able to see this, and if you fill in the feedback, you'll get the slides. And effectively, I just tried to summarize all of the important sexually transmitted infections into one table, and also highlighting in red the important things or the buzzwords that tend to be used in questions from what I've seen to help you remember each of the different ones. So for chlamydia, the symptoms and signs will all be very similar, but usually you get cervical excitation. Investigations will be a NAT, which is a nucleic acid amplification test. So that will either be a swab or a urine sample of that. The treatments nowadays used as doxy because azithromycin is becoming more resistant to this, and it's the most common bacterial STI. So if you ever have to pick between chlamydia and gonorrhea, unless it is very obviously trying to point more at gonorrhea by saying things like a watery green yellow discharge, opt for chlamydia over gonorrhea. The other thing to bear in mind is I've abbreviated some of these things. So IMB is intermenstrual bleeding, PCB is postcoital bleeding. Syphilis is a slightly weird one because you've got obviously different stages of syphilis. You've got primary, secondary, tertiary. And the thing they like to ask about is the investigations. To be aware of, the treponema ELISA test stays positive for life, no matter which stage of syphilis you're at, whereas the VDRL rises in early disease and then falls as treatment progresses. And so it's actually quite a good marker to ensure that there is successful treatment of the disease. We talked about genital warts and genital herpes, and PID obviously was a question that was originally mentioned. Usually it's triple antibiotic therapy with doxy, ceftriaxone, metronidazole. Okay, if there's no more questions, we'll move on to the next SBA. In this question, the 25-year-old female is gone to her GP. She's requesting emergency contraception because she's had unprotected sexual intercourse 60 hours ago. Her last menstrual period was 6 days ago. She normally takes the combined oral contraceptive pill, but has missed this over the last 2 days, a urine pregnancy test is negative. So what would you advise her? Another 15 seconds. Okay, as most of you got this correct, it is indeed levonorgestrel. So just to go through the question, hopefully just to clarify a couple of things. The 3 important things to remember with emergency contraception is the 3 types. So you have your copper IUD, and you have your levonorgestrel, and you have your ulipristal acetate. The copper IUD is the first line. It is inserted up to 5 days after unprotected sexual intercourse, whereas ulipristal and levonorgestrel have more limited timeframes of 72 hours for one of them. Actually, 5 days for ulipristal and 72 hours for levonorgestrel. She meets the timeline for all 3 options in this case, and a copper coil would be the best option for her, and that's the one you should really recommend, but it is not one of the options. So levonorgestrel is your best option. In this case, she also takes a combined pill, so this is also testing you on whether you know your missed pill rules. So if you remember your missed pill rules, then you'll know that if she missed 2 pills or more, then you effectively are not said to be protected, and therefore you continue and you carry on, but you have to wait up to 7 days till you can be considered protected. So they always recommend you use a second method of contraception. Move on to the next one. I've changed age this time. So we've got a 38-year-old who has come into the GP asking for some contraception. She has 2 children from a previous marriage, and she's now in a new relationship. She doesn't want any more children. She has regular heavy periods, but is otherwise well, and she has no past medical history. So what would you advise her? Okay, I think everyone's answered. I'm going to stop the poll, and all of you got it correct. Hooray. And in this case, it's a myrenal coil. She's 38, she's got no past medical history. You don't know about things like smoking history or anything like that, but you know that she's got heavy periods. And so the first line for menorrhagia, let alone contraceptive options, is the myrenal coil, because it tackles both contraception and heavy periods. I think we can all agree that a laparoscopic sterilization and a hysterectomy, although possible and appropriate, although possible, is completely inappropriate because of how invasive it is. And she's still only really 38, and she may change her mind, and these are more definitive options. The combined pill, because of her age, and we don't know really about the other things like her BMI, we probably would err on the side of caution for a combined pill. And the copper coil, although absolutely fantastic as a form of contraception, would give her even heavier periods. If she's already got heavy periods, she probably wouldn't want that. Again, this is just a really nice slide with two things on it. The first one is emergency contraception and the three different types, and also when it's indicated, and how it relates to effectiveness, side effects that they can ask you. I think if you use logic and you know the mechanism of action of the different types of contraceptives, so in this case, if you know that ulipristal acetate and your levonorgestrel are effectively going to prevent ovulation, then you can time it in terms of the menstrual cycle based on that. So although it is still a recommended option even after you have technically ovulated, usually if you think about it, it probably wouldn't be as effective if you've ovulated already. In our question, the lady that we were talking about hadn't reached her stage of ovulation because she was only on day 6 of her cycle. And the other one is, how do you make a decision about emergency contraception? And it's from the FSRH, which is a great little diagram to remember, especially if you're a very visual person. Right, and again, this is a different one which I found quite useful, and that's just to kind of give you a brief idea of different types of scenarios that they can put in questions, and ones that would be indicated in certain scenarios. So if you have someone who's quite young, then you probably want to use something less invasive, so something like the combined pill or the progesterone-only pill, and the other ones things are like postpartum. So one thing I will say though is it says it's no contraception required till 21 days after delivery. Never tell anyone that. Breastfeeding is not the most effective form of contraception. So that's the only thing I will say that I wouldn't trust about this particular table. Probably should have crossed that bit out. But the progesterone-only pill and things like the implant are fairly safe options to give. You can then start the combined pill at later stages, like 6 weeks after if you're not breastfeeding, but if you are, after 6 months. And in terms of things like coils, we do offer it to people who do have cesareans, but the risk of them falling out is quite high, because if you think about it, the uterus is much bigger due to the pregnancy and it needs to come down to its normal state, which only happens really truly by around 6 weeks. So we're almost towards the end, promise. So the next SBA, so 55-year-old female comes to her GP. She's complaining of hot flushes, heavy night sweats for the last 6 months. Her last menstrual period was 2 years ago. She still has her Mirena in situ because she had heavy periods in the past. So what treatment would you consider for her in this case? I've been a little bit mean because I've not told you what each of these things are, but hopefully you can work it out based on the names. Give it another 10 seconds, waiting for one more response. You guys are good at this. Usually people shy away from menopause. So in this case, the correct answer is A, Less Solo. So it's 5 options. Less Solo is an estrogen only tablet. Vagifem is a topical, so a local treatment of estrogen. Everol Sequi and Fem7 Conti and Everol Conti are a mixture of progesterone and estrogen together. So we know this woman's menopausal because her last period was 2 years ago. When considering HRT, you want a full history to know any obvious past medical history and things about VTE cancer, which would then be contraindications to using HRT, but that's another separate aspect of it altogether. And the next step is then uterine function. So if she had a hysterectomy, or in this case, if she's got a Mirena, you've already got progestogen in place, or you wouldn't need progestogen because you've got no uterus, and therefore your risk of endometrial hyperplasia or even endometrial cancer is low. And so you only really need something that would act as an estrogen. The Vagifem is an estrogen-only option, but it's only a local treatment. You usually just put it in the vagina, and usually it's used to treat atrophic vaginitis, which is quite a common symptom. So just some important things. Menopause is when menstruation stops. Postmenopausal period, or someone is considered only postmenopausal 1 year after her last period. And if you're perimenopausal, it's between menopause and postmenopause, which is hopefully obvious. And it's a clinical diagnosis, and very rarely people use an FSH level to assist with diagnosis. And that's usually in younger women who show signs of possible premature ovarian insufficiency. And if they're perimenopausal, we always like to use cyclical combined HRT, and after 1 year they can usually then move on to continuous combined, even if they're still kind of perimenopausal. But if they're postmenopausal, you can use a continuous combined option. And as we mentioned, if no uterus, then estrogen only is absolutely fine. That's your next question. We've got a 29-year-old who's come to a fertility clinic. She's been struggling to conceive for 18 months. She tells you that her menstrual cycles are irregular. She's had a period over 3 months ago. She has a BMI of 28. Her GP has done some blood work and a transvaginal ultrasound, which is in keeping with the diagnosis of polycystic ovarian syndrome. What medication would increase her chances of conceiving? And this time I've given you the mechanism of action of each of the different options. Oh, everyone's answered? Perfect. So the majority of you got it correct, which is clomiphene. So polycystic ovarian syndrome is a condition that's diagnosed by the presence of two out of three key symptoms, which is oligo or amenorrhea, polycystic ovaries, and clinical or biochemical signs of hyperandrogenism like hirsutism or high testosterone level. Long-term risks of PCOS is the fact that you are at higher risk of endometrial hyperplasia, sleep apnea, developing diabetes, and really diet and exercise and making sure that your weight's well controlled is the key to preventing long-term complications. The reason why it's not metformin, as some of you might think about, is because the question here is asking you what is the best, is effectively a single best answer. So of the two options, the single best answer really is clomiphene, which is actually what we use if they come to fertility clinic. But yes, metformin, they should be starting on both metformin and clomiphene if their BMIs on the obese range. So her BMI of 28 is kind of borderline in that respect. Next one. We've got 15 SBA, so we're nearing the end, promise. So 29-year-old female, also referred to fertility clinic. She's been struggling to conceive for the past 18 months. She also explains to you that her cycles are painful and irregular. Her last period was 3 months ago. She's also got a BMI of 28, but this time you do an examination and you know that she's got a fixed retroverted uterus. You note from her GP that she's had a transvaginal ultrasound because they're great GPs. And so that one showed 4 centimeter cyst with ground glass appearances in keeping with a possible endometrioma. So what would be your next steps? wait another 10, 15 seconds. Hey, perfect. So most of you got it correct. I did try to chuck in one that was a little bit mean. And the correct answer is you do a pregnancy test. She's not had a period for 3 months. She's been trying to get pregnant, so she's probably not using contraception. So don't forget to do a pregnancy test because she might just have fallen pregnant spontaneously. The other options are treatment options that you can use for endometriosis. Well, pelvic MRI is not one, but it is helpful to assist in the diagnosis of endometriosis, but it is not the gold standard. The gold standard is actually a diagnostic laparoscopy. And in women who are trying to get pregnant, because most of the options of treatment are usually hormonal, you tend to actually go for a laparoscopy to confirm the diagnosis and do an adhesiolysis because that really does help their fertility. So this is useful a lot more for your OSCEs, because if you think about it as subfertility as ovulatory, tubal, you've got endometriosis, which is one of its own, uterine abnormalities, so eggs, tubes, uterus, and then you've got your male factors. So that's really the key ways to think about it. I'm not going to go over the whole thing because it is something that you look at on the YouTube and or even get the slides to actually look at in more detail. But that's the way I think about it in terms of subfertility. And again, in terms of options, it will depend on the type of these. So ovulation, if it's an issue, if it's tubal factors, that's an issue. If it's uterine factors or if it's male factors, you'll have different options. Just to note, their IVF is what most people actually know about, and that's using fertility drugs to stimulate the ovaries to produce mature eggs. You then retrieve these, you fertilize it in a lab with a sperm from either a partner or a donor, and you kind of wait for fertilization, then you put them back into the woman. IUI is intrauterine insemination. So effectively you're taking the sperm and putting it inside the woman. And then you've got ICSI, which is actually a refinement of IVF, which is basically where they take, if you've got a male factor reason as to why you can't get pregnant, they take the best single healthy sperm and they extract it from the sample that the male gives, and they inject it directly into the egg to fertilize it. So it's basically a refinement of IVF. Fine. I mentioned PCOS already. Hopefully that's fairly clear. I'm not really going to go over this anymore and bore you to death, unless there is any big burning questions. Again, endometriosis is quite common. Growth of endometrial tissue outside of the uterine cavity could be anywhere, but often tends to be kind of near the pelvic area. Extra pelvic deposits like in the lungs, so some people can actually get hemoptysis, for example, but again, these are very rare, and it has to be usually very severe. And really, as I mentioned before, gold standard diagnosis is laparoscopic exploration. But just to bear in mind, it takes quite a long time to actually diagnose. The key symptoms are pelvic pain, infertility, and usually, or subfertility, and usually it's menstrual problems, so usually painful periods, or even painful sex. And the reason I put management options depend on the symptoms is because, as we mentioned before, for fertility, you'd want to do something like a laparoscopy and adhesiolysis. But say if they had dysmenorrhea, then you might want to give them the option of, say, a Mirena coil to alleviate their symptoms, as well as things like, mefenamic acid, that kind of thing, if they didn't want a hormonal option. So this is the next question. 29-year-old Afro-Caribbean descent. She's feeling tired, so she goes to her GP. Blood test shows she's anemic. She's got a HB of 95. And on further questioning, she tells you she's got a 40-day cycle with heavy periods. On bimanual examination, you feel a 20-week sized uterus, which is firm and non-tender to touch. What is the most likely diagnosis? Which I think hopefully most of you should be able to get. Give you like 10 more seconds. Okay, I'm going to stop the poll, and all of you got it correct. It is uterine fibroids. Again, it's more about this being this, what is the single best answer. You could have mentioned pregnancy, actually probably a very valid point, but everything is pointing towards fibroids in the actual body of the stem of the question. The reason I mentioned 20-week size uterus is because that's how we actually measure it as obstetricians and gynecologists. That's what we refer it to when we feel a mass in the abdomen. This time I've done the right thing and put fibroids right next to the question so we can go over it very quickly. So they're benign smooth muscle tumours of the uterus, and they are usually hormone dependent, which means that they actually shrink once you get to menopause. But it also means that when you are pregnant, the fibroids can actually cause significant amounts of pain, and they can cause degeneration. So some questions will say that this woman has fibroids, so she's coming with significant abdominal pain. You've ruled out, risk, labor or threatened preterm labor. And what's the most likely diagnosis? And usually they'll have a low-grade fever as well, and that's usually fibroid degeneration, and is usually referred to as red degeneration. You've got different types of these, so they can either be in the muscle, in the serosa. If they're submucosal, then they will be on the endometrial lining, and so that's what often causes the menorrhagia. And really, a hysteroscopy is actually a really good way to look for these submucosal fibroids, but a transvaginal ultrasound will really give you a better picture of how many fibroids, where they are, and what we can do. And again, management similar to endometriosis will depend on how big are these fibroids, what symptoms is this person getting, because some people don't get any symptoms and have fibroids, and do they or do they not want to get pregnant? And so these will either be medical or surgical. Fine, last pit stop tour, gynae malignancies. So we've got, including this one, 3 questions. So you've got a 27-year-old, she's sexually active. She presents for her routine cervical smear. The sample tests are positive for HPV, but there is no evidence of dyskaryosis. What would be your next step in management? Okay, I think everyone's answered, so I'm going to stop the poll. So the 50-50 one, really, it's all about whether or not you know the cervical screening pathway. So she's got, and this has changed, I think, in 2019, if I'm not incorrect. But really, the next step is that you'd repeat the smear in a year's time, because you would have hoped that the HPV would have been cleared by then. Usually women take 1 to 2 years to clear HPV if they do have it. This comes from Teach Me OBGYN, and it's I think a really nice diagram that shows you what to do. depending on what you have in the smear. So previously, they used to actually do cytology straight away, but this time, because predominantly almost all of the cervical cancers that you have are associated with HPV, you actually test for HPV first. So if it's negative, just routine screening is fine. They don't even do cytology. If it's positive, then you need to check for the cells. Is there any evidence of dyskaryosis or not? If there is no evidence, then you repeat the smear in a year's time, which was the case in this lady. But if it's abnormal, then you send them to colposcopy. And if it's an inadequate smear, then you have to repeat it again in 3 months. If again it remains inadequate, then you just send them straight to colposcopy. Hopefully you all know what colposcopy is. If you don't, it's effectively a clinic where they use special types of dye, so acetic acid, to look at the cervix in greater detail with a very cool looking microscope. And it's where things like biopsies truly take place. Remember, it's cytology in this case. So they look at just the way the cells look rather than it being a true diagnosis of cervical cancer. So cervical cancer is associated most with HPV. The key ones to remember are 16 and 18 because they are involved in your HPV vaccine, and they're the ones that most likely will be asked in your SBAs. The signs and symptoms, the most common one is things like postcoital bleeding and painful sex. And we also know about CIN, so cervical intraepithelial neoplasia, which is effectively your precancerous changes that occur before you do get full-blown cervical cancer. Everything is on there. Usually we pick up CIN through cervical screening when they go to colposcopy, and we usually treat it with either a LETS, which is large loop excision of the transformation zone, and effectively you're using a laser to remove a slice of where that area is, or you can do a cone biopsy, which is the traditional way of doing things, which I haven't really seen done much nowadays. Fine, next one. You now have a 70-year-old. She's had 2 episodes of PV bleeding. She's come to you via the Rapid Access Clinic. She's had a transvaginal ultrasound, which shows a 6 millimeter endometrium and a 3 centimeter simple ovarian cyst. He is hemodynamically stable. So what would be your next step? Okay, let's stop the poll. So most people didn't quite get this, and the reason is because the key bit in the question is what would be your next step. So she's 70, so you can presume she's postmenopausal. So this is referring to postmenopausal bleeding. She's got a 6 millimeter size endometrium. Usually you expect it to be less than 4 millimeters. That's the important thing to know. So you know she's got a thickened endometrium. The 3 centimeter simple ovarian cyst is a bit of a red herring that I threw in there. And so a CA125, yes, you would want to do actually for the ovarian cyst, but that's not what she's come in presenting to the Rapid Access Clinic. The thing you want to rule out with postmenopausal bleeding is that it's endometrial cancer. So really, the best option is to do a papel biopsy in clinic, which if you haven't seen, it effectively looks like a straw, and it's got a straw and a kind of a, it's a straw with I guess an extra aspect to it, which effectively creates a vacuum. It's a bit like a syringe, but in the form of a straw, in terms of size wise, so that it can enter through the cervix, and you can just take a very randomized sample of cells with that and send them off to the lab. Realistically, some of you are correct, she would need an outpatient hysteroscopy, but really you only straight away refer to outpatient hysteroscopy when you have something like an obvious polyp, which you know you can remove. But yes, outpatient hysteroscopy would be the next step after the Papel biopsy in clinic, because you'd want to try and get some biopsies, but you know, they would be random. And even in an outpatient hysteroscopy setting, some people would still use a Papel biopsy. So hopefully that's a little bit clear. Endometrial cancer is the fourth most common cancer, most common gynae cancer. So, and the most common presentation is endometrial, is postmenopausal bleeding. There's plenty of risk factors there that I'm referring to. And really, the way you can remember them is about estrogen exposure. So things like obesity, because you've got extra fat and extra adipose tissue, then you're going to produce more estrogen. If you have early menarche, so if you start your periods early and you end your periods late, then that's again more estrogen exposure in your lifetime. If you were not pregnant ever, then again, it's estrogen, more cycles, more menstrual cycles that you've gone through, more ovulatory cycles that you've gone through. And things that are protective are things like the contraceptive pill, the combined contraceptive pill, and actually even continuous combined HRT is protective. And again, it's more about minimizing exposure to estrogen in the follicular phase of the menstrual cycle. And so that's how it works, actually, mechanism of action. So hopefully that makes sense. Cool. So last question. 49-year-old, she's come to A&E, she's got gradual onset abdominal distension. She's now causing a severe constipation. And she mentions to you that she was feeling bloated for several months. She's been having some urinary frequency, and she's also had some weight loss. So what's the most likely diagnosis? I think this one is probably a cheeky one because you probably will know it's gynecological in nature. But I guess if you had this other question in your exams, it might be a different answer. So in this case, you are correct. It's ovarian cancer. She's got abdominal distension, probably in keeping with ascites, and is probably compressing the bowel. In this case, a colorectal cancer is probably your most likely diagnosis, but actually, I wanted to really allude to ovarian cancer. We talked about, we had an ovarian cyst in one of the previous questions, which is why I included a little bit about ovarian cysts. Ovarian cysts are very common. They're just fluid-filled sacs within the ovary, and they are very common, especially in premenopausal patients. And most of them are benign or physiological cysts, like your corpus luteal cyst, which occurs if you have a cyst and you're postmenopausal, then your GP will usually do a risk of malignancy index, which is basically a tool that's used in practice to determine the likelihood of this being a cancer and whether or not this needs to be referred to a cancer centre for treatment as indicated. And this would include a CA125 as well as the type of cyst that you have. If it's a simple cyst, obviously that's not showing any signs of possible malignancy. If it's got lots of locules, if there's any solid aspects to it, then that would be more indicative of possible ovarian cancer. Ovarian cancer has very non-specific symptoms, and therefore most people present with late-stage disease. The most common type is serous cyst adenocarcinoma, and the key buzzword that they sometimes put in questions is Samoma bodies, and that's how you can differentiate between the different types. Your investigations are, as you would expect, bloods, including a CA125, so you can work out your risk of malignancy index, as well as transvaginal ultrasound, and then you'd want to talk about staging and actually looking at things in more detail. So you do a CT and an MRI and plus minus biopsy. So I think that's everything that I wanted to talk about. Ovarian cysts, the only problem that you need to be aware of is if there's an ovarian cyst accident. So if they bleed, if they tort, so you can lose an ovary, or if they rupture, and they can cause significant amounts of pain, and they may need surgery for that. Okay, so just some final things. The RCOG Green Top Guidelines, your textbooks, Teach Me OBGYN, Zero to Finals, Past Medicine, those are your best friends when you're trying to revise for these things. I hope that this was useful, and thank you very much. I'd be very grateful if you could fill in the feedback form, and you'll get access to the slides once you submit it. And thanks for joining tonight.
Thanks again, Aisha, for doing the session. Please do fill in the feedback form, and if you're watching on YouTube, we keep the feedback form open for a while, so please do fill it in.